And if it occurs only for some milestones, this is considered specific. And after 5 years of age, intellectual and physical disabilities are described rather than the term developmental delay, because the child is not expected to catch up after a specific age limit. So basically, developmental delay predicts a diagnosis of intellectual disability in the future. So for the epidemiology, first of all, in the United States, roughly 15% of children have been reported to have at least one developmental delay, and this is why it's necessary to important development and screen for the presence of these problems at health visits. It also has been shown to have a similar prevalence among males and females, and it's more common in developing countries. For the etiology, careful evaluation can actually reveal a cause in 50 to 70% of cases, and we can divide etiology into prenatal, perinatal, and postnatal causes. For the prenatal causes, this could be further divided into biologic and environmental factors. So let's start with the biologic factors. So this includes genetic mutations like chromosomal abnormalities. And what examples do we know about chromosomal abnormalities? We have Down syndrome, Fragile X syndrome, chromosome microdeletions or duplications. Next, we have CNS abnormalities, so like tuberous sclerosis and neurofibromatosis. So this is for the biologic causes. Now we'll go on to the environmental prenatal causes. So we have fetal exposure to teratogens and toxins like smoking, alcohol, or opioids, or even prescribed medications like anti-epileptic drugs. We also have maternal infections, whether it's early, like rubella, cytomegalovirus, or toxoplasmosis, or late maternal infections by varicella, HIV, or malaria. And we have maternal hypothyroidism, because the first few months of pregnancy, the fetus relies on the mother for thyroid hormones, and thyroid hormones play an essential part in normal brain development. So this is for the prenatal causes. We'll move on to the perinatal causes, which includes prematurity. So it's birth of a baby fewer than 37 weeks of gestational age. We have birth asphyxia, which is when a baby's brain and other organs do not get enough oxygen, or neonatal complications, like metabolic symptomatic hypoglycemia or hyperbilirubinemia. And now we'll move on to the postnatal causes. So we have trauma, whether it's physical or psychological. Physical trauma includes accidental or physical abuse, and psychological trauma could include like child maltreatment. We have anoxia, which is when the body or brain completely loses its oxygen supply. Vascular causes like stroke, infections, which are acquired infections like meningitis and encephalitis, lead poisoning, and inborn errors of metabolism like phenylketonuria, which is a defect in the gene that helps create the enzyme phenylalanine hydroxylase. And phenylalanine hydroxylase is responsible for processing phenylalanine into tyrosine. So without this enzyme, phenylalanine would accumulate, and irreversible brain damage and marked intellectual disability begins within the first few months of life. Okay, so this is for the etiology. Now we'll move on to the risk factors. So first of all, we have developing countries and low socioeconomic status. We mentioned this before in the epidemiology, and I found this research explaining the correlation between the developmental delay and developing countries. And it explained the major risk factors for developmental disabilities in some low-income countries, including specific genetic illnesses, a higher frequency of births to older mothers, consanguinity, and specific micronutrient deficiencies and infections. And I've left the link here for whoever is interested to further read about this research. Now going back, we have consanguinity, which is a well-known risk factor for genetic disorders, including diseases and syndromes that present with intellectual and developmental disabilities. And this is mainly due to the autosomal recessive inheritance. We have nutritional deficiencies, including iron, B12, and zinc, and that could lead to neuronal regression and developmental delay. And for the rest of the risk factors, we've already discussed them before. So like teratogen exposure, alcohol or drug, maternal chronic illnesses like hypothyroidism, and prematurity. Okay, so as we mentioned before, the red flag in order to consider a child developmentally delayed is when the child does not acquire a skill within a certain age limit. So let's start with the gross motor delay. And this may present as a delay in acquiring motor skills like head control, rolling, sitting, crawling, standing, and walking. And concern about motor development usually presents between 3 months and 2 years of age. And this is when acquiring motor skills is occurring most rapidly. And the most common causes include CNS causes like cerebral palsy. We have congenital myopathies and spinal cord lesions. Examples of this include a baby who cannot control his head by 4 months, cannot sit unsupported by 9 months, cannot stand supported by 12 months, and cannot walk independently by 18 months. Next is fine motor delay, and it involves a delay in using fingers and hands. This includes like holding a toy and using a crayon. And it presents similarly to the gross motor delay between 3 months and 2 years. And the most common causes include central nervous system, like cerebral palsy and neural tube defects. Example of this includes a baby who cannot transfer objects from hand to hand by 9 months and cannot pincer grasp by 12 months. For speech and language delay, it could be expressive or receptive. Now, expressive is the inability to produce or use language, and receptive is the inability to understand language, or it could be both. And the most common causes include hearing loss, which is actually a reversible cause of speech, language, or even social delay, anatomical abnormalities like cleft lip, which could be corrected surgically, cerebral palsy that could lead to oromotor incoordination, and unfortunately, lack of social interaction, which is a very common cause that we're seeing nowadays. Example of this includes a baby who cannot produce nonspecific babble by 10 months and cannot say a word by 2 years. For cognitive delay, it's when a child exhibits learning difficulty or disability and includes either organic causes like CNS abnormalities or environmental causes like social isolation and child abuse. Example includes a child who cannot do symbolic play by 2.5 years and cannot do interactive play by 3.5 years. For social and emotional delay, which is our last one here, it's when a child who fails to acquire normal social and communication skills or expressing feelings. And this is when it's called socially and emotionally delayed. And a common cause is having autistic spectrum disorder, which is prevalent in 3 to 6 out of 1,000 live births and is more common in males. Presentation is usually between 2 and 4 years of age when language and social skills normally expand, and environmental factors like social isolation and abuse. Example of this includes a baby who cannot smile responsibly by 8 weeks, do not express fear of strangers by 10 months, and cannot point to wanted items by 2 years. Note that a developmental delay in one milestone could lead to a delay in another. So this is very important to keep in mind. For the approach, a comprehensive history and thorough physical examination are essential elements to examine in children with developmental delay. So first of all, a detailed history of child's development from conception to current age is obtained and reviewed. And we would do this by obtaining the antenatal, the neonatal, and the postnatal records. So for the antenatal records, as we discussed before, we will be asking for risk factors such as teratogen exposure, drug history, and any maternal illnesses. For the neonatal history, we would ask whether the baby was delivered at term or preterm, and we would check for neonatal adverse effects like hypoxia, jaundice, hypotonia, or hypothyroidism, or congenital malformations. We will also obtain the APGAR score, which is a quick test performed on a baby at the 1st minute and 5th minute after being delivered. And this 5-minute score tells us how well the baby is doing outside the mother's womb. And it consists of 5 components, which are the appearance, so the color, the pulse, the grimace, which is the reflexes, activity, and respiration. And a score is given from either 0, 1, or 2 for each component. And let's not forget to ask about the social history. So we'll ask about consanguinity, socioeconomic status, and caregiver, like symptoms or signs in a neglected child, and developmental milestones, nutritional history, and family history. For the physical examination, first of all, we will be looking for the vitals, Then we'll be doing the growth parameters, which are the head circumference, weight, height, and BMI. We'll be doing a general physical examination involving head-to-toe assessment. We'll be doing a detailed neurological exam, including hearing and vision evaluation, and examination of dysmorphology, again from head to toe. And additional information can also be gathered by a play interaction with the child using age-appropriate toys. So you can give a child a toy car, blocks, crayons, and paper, and you can watch the child move around the clinic. Now for the investigations. So they're basically here to guide us for diagnosis, and it depends on the milestone field and the suspected cause. So if we're suspecting a motor delay, neurological examination and assessment of milestones and primitive reflexes is required. If we're suspecting a CNS cause, we can do neuroimaging, like MRI of the brain, to identify CNS malformation, intracranial bleeding, or hydrocephalus. We can do a vision assessment, which includes color and contrast discrimination and near and distance acuity discrimination. And we can do genetic testing if chromosomal anomalies are suspected. For speech and language delay, hearing assessment is performed by an audiologist to evaluate the child's sense of hearing. Speech and language assessment is performed by a therapist. For cognitive delay, an IQ test is performed. And finally, for social and emotional delay, a detailed psychological and social evaluation is done. For management, this is our last slide. Assessment of developmental delays often requires the work of a team with experts in general and specific areas. So it's basically a multidisciplinary approach. And this starts with the primary care providers, followed by pediatric subspecialists, like as indicated, like physiotherapy, occupational therapy, speech therapy, behavioral therapy, and other pediatric subspecialists as needed. This comes to the end of my lecture. I have two questions at the end. Who would like to read the first one?
I can read it.
Can I do this one?
Okay.
Yeah, sure.
At what age should a child be referred to a pediatrician if they cannot walk independently? The answer is 18 months because they should be able to walk independently by 15 months.
Yes, excellent. Thank you, Rahaf. Okay, for the second question, who would like to read it?
I can read it.
Sure.
Okay, so a 2-year-old girl is brought to the physician for a well-child examination. She can run but is unable to walk up and down the stairs. She can copy a line but cannot draw a circle or a plus sign. She knows 6 words but is unable to speak in the 2-word sentences. She displays selfish behavior when interacting with other children. She is unable to dress herself. Which of the following is the most appropriate assessment of her development?
Okay, let's go one by one here. So for the gross motor, it says that she can run but is unable to walk up and down the stairs. Do you consider this normal?
Delay. Yes, it's the delay.
Yes, because she cannot walk up and down the stairs, and 2-year-olds are supposed to do that without alternating feet. Next, we have this fine motor delay. So it says that she can copy a line but cannot draw a circle or a plus sign. Is this normal?
Yeah, it's normal for her age.
Yes, it is normal. Okay, for language, she knows 6 words but is unable to speak in 2-word sentences. What do you think?
So, yeah, it's a delay.
Yes, it's a delay, that's right. For social skills, she displays a selfish behavior. And
Yeah,
she's
that's
unable
normal.
to. Yeah, that's normal. So what do you think is the answer?
D.
Exactly. Thank you so much. Thank you for listening. I'm happy to answer any question.
Thank you, Hala. Well done. This is a very extensive review about development. Anybody having any questions?
All is clear, doctor. Thank you.
So, Hala, if you go back to the Alberta developmental chart that you presented.
The research?
The one that the table for developmental milestones.
Oh, okay.
The green one. Okay, this is. So, as Hala mentioned, it is very important to assess the child development It is really very important first questions to the mother regarding of the child age. The second questions, I believe Hala already she passed, is to ask about prematurity. Is it a full term or premature babies? Right? Because we know for all premature, we have to do corrected age before we plot them on the developmental milestones. If I give an example, if we have, for example, Nada, and she presented to this clinic at 18 months of age, and the mother told you she is an ex-premature 32-weeker.
Yeah, this is considered premature.
So what is Nada's developmental age? Yani how we can do corrected age for Nada?
I think it's the gestation, so she was delivered at 32, and her current
32?
age right now.
Yeah, 18 months.
She's 18 months, so 32 plus 18.
Plus or minus?
I believe it's plus.
So what is the definition of full-term children? When we say this neonate is a full-term baby?
I think it's like above 37 weeks. Like that's like above yani.
Yeah, the question for you and for your colleagues, the definition of full-term is 37 completed weeks, right? So if we want to do correction, we do it upon 37 weeks. So in our example, Nada, she was born at 32 weeks. This means she needs how many weeks to be 37? 6 weeks, which roughly around 1.5 months, right?
Mm-hmm.
So this means Nada corrected age is 15 and a half, or yeah, 15 and a half months or 14 months of age. So if Nada, for example, cannot walk independently by 18 months of age, this is, it doesn't we cannot say this is a developmental delay, because she is the reason she is a premature and her corrected age is almost 14 and a half months. So this means if she is doing the milestones at 18 months, fair enough. If she cannot, we have to do corrected age. So for all premature, until they are 2 years of age, gestational, we should do corrected age before we judge about the child developmental milestones. And the other reasons, because premature is one of the reasons, depends on the age of prematurity, to be a developmentally delayed. So extreme premature, like 24-weeker, different than 36 weeks, right? Complication like retinopathy of prematurity, intraventricular hemorrhage, sepsis, hypotension, presence of congenital heart disease, long NICU stay, all those factors can affect the child development and be a reason of the child developmental delay. So this is why for premature, we have to do corrected age. So this is one point I would like to highlight. The other point, we do have developmental delay, and we have also what we call it regression of milestones. Regression of milestones means when somebody was normal doing the developmental milestones around the appropriate age and now lost all milestones. What is the difference between delay and regression? Regression is worse prognosis. This means something metabolic or something ongoing leading to developmental delay. However, in developmental delay, based on the cause, can be corrected by doing, for example, occupational therapy, physiotherapy, referral to speech and language, and etc. And one of the common reason or commonest reason of regression of milestones is metabolic disorder, neurometabolic disorder like galactosemia, tyrosinemia, Niemann-Beck, and etc. Right? Any questions to Hala?
I have a question, doctor, regarding the milestones. So is there a limit or a specific age where we say from now on, this preterm baby would be normal or following the normal developmental milestones?
Yeah, until 2 years of age. After 2 years of age, as per studies, it shows that both full term and premature going to be same in terms of development and also in terms of growth. I mean, weight and height, head circumference. So until 2 years of age, we have to do corrected age. After 2 years of age, expectation that even premature catch up with the development.
Thank you so much, doctor.
Thank you, Hala. Thank you. It was very well done.
Thank you, doctor.
Doctor, so do I start now?
Yes, go ahead.
تمام. Okay, so Assalamu alaikum everyone. I'm Ali Ad-Dumani and I'll be giving the last lecture for today, which is common ophthalmological problems in children. So I know today was a long academic day, so I made sure my lecture is simple and straight to the point. If you have any questions as we go through the lecture, feel free to stop me at any time. So Bismillah, these are the objectives for today. We'll be covering different topics in this lecture, starting with amblyopia, then strabismus, cataract, retinoblastoma, congenital glaucoma, retinopathy of prematurity, and finally ending the lecture with conjunctivitis and refractive errors. So let me start with a very brief and quick review on the basic anatomy of the eye, so you can correlate it with the pathology of the disease. So here you can see the pupil, this is the lens, and here is the cornea. Here inside is the vitreous body, and at the back of the eye we can find the retina, and this is the optic nerve. So amblyopia. Let's think if the brain doesn't know the eye is doing what it's supposed to do. So it's going to turn off the signals coming to it. So when there will be lack of vision in one eye or rarely both because the eye and the brain aren't working together. The brain will focus on the eye that's normal more than the other. So the weaker eye will receive less visual signals and eventually the ability of this eye to work decreases. So let's read the definition. It's visual decrease in one or both eyes due to a developmental vision disorder during early childhood. Pathophysiology. One or both eyes will convey poor or mismatched visual information to the brain. What happens next is that the brain will suppress the information from one or both eyes, leading to disuse of the eye and lack of visual stimuli. How can it happen? It comes in three different forms: deprivation amblyopia, refractive amblyopia, and strabismus. Deprivation, it results from obstruction of the eye, light into the patient's eye. Now let's think, what conditions can cause obstruction of light into the eye? It can be ptosis, cataract, or occlusion. Refractive amblyopia, it's caused by the unequal refractive errors between the two eyes, and we'll be talking about refractive errors in a bit. So let's take an example. If one eye is suffering from uncorrected nearsightedness and the other eye is normal, in such cases, the brain will rely on the eye with no problems and will ignore the blurred vision from the other eye. So the eye that provides the brain with a clearer image becomes the dominant one. Strabismus amblyopia is the imbalance in the muscles that position the eye. This can also lead to amblyopia. Now, early detection of amblyopia or even risk factors of it improves visual outcomes. That's why it's very important to be detected early in life and promptly treated. However, unfortunately, if not treated, it can lead to severe visual disability and blindness. So diagnosis is clinical. It's very important also to be detected before the age of 6. So an early eye check is equally important also if there is this family history of crossed eyes, childhood cataracts, or any other eye conditions. For the treatment, there is no treatment. However, it can be prevented by treating underlying cause. For example, if the patient is having strabismus, we can try to treat strabismus. If the patient is having refractive errors, we can try to treat them. So now moving to our next topic, which is strabismus. I believe you're more familiar with strabismus. So as we mentioned, it's imbalance in the muscles that position the eye. It's also called lazy eye. So we can think of it as both eyes do not look at the same place at the same time. So strabismus is the condition of misalignment of the eyes. It can be horizontal, vertical, torsional, which is rotation of the eye, or a combination of these. Strabismus occurs in approximately 2 to 4% of the population. Risk factors, family history, of course, preterm birth or low birth weight, ocular conditions such as ptosis, cataracts, retinopathy of prematurity, neuromuscular conditions such as cerebral palsy and muscular dystrophy. So now how can you treat strabismus? If it was congenital, so from birth, mainly surgeries are done in such cases. However, if it was acquired later on in life, we can patch the good eye, which is called the occlusion treatment. So occlusion treatment is an option for strabismus by covering the good eye, which results in training the weaker one. So in this way, we can prevent visual impairment. Treatment at an early stage is essential to prevent complications such as we mentioned amblyopia, diplopia, which is known as double vision, so the patient sees two images of the same thing, and secondary contracture of the extraocular muscles. How can we know that this child is having strabismus? Clinically, of course, in addition to history and physical examination would also aid us. So corneal light reflex test is also called Hirschberg test. It's a test for determining if the eyes are in alignment or no. So what is done is that a light is shown at the eyes and the location of the light reflex on the cornea is observed. Normally, light reflexes are usually symmetrical and seen in the center of the eye, center of the pupil. However, if there was asymmetrical corneal reflections, this indicates that the visual axes are not aligned. Now let me show you this video. It's really helpful in understanding how this test is done. Okay, so in this patient, we can see that the light reflex is symmetrical in both eyes. It's in the center of the pupil, also in both eyes. However, in this case, which is esotropia, in this eye, we can see that the light reflex is in the middle, which is in the center of the pupil. However, in this eye, it's not in the center, it's in the periphery. So this is abnormal. This is another case. Here it's abnormal. So coming back to our lecture, we have a condition called pseudostrabismus. So from its name, pseudo means false, so false strabismus. It's the false appearance of eye crossing that occurs mainly in infants and children with wide nasal bridge, as we can see in this picture, and large apicanthal folds of the eyes. These are the apicanthal folds of the eyes. So it's not true strabismus, but rather these conditions are making the eye appear strabismic, particularly when the child looks in lateral gaze, as we can see in this image. So does the strabismus occur in only one direction? No, we have different types of strabismus: esotropia, exotropia, hypotropia, and hypertropia. So esotropia is medial deviation towards the nasal part, exotropia is lateral deviation, hypo is downward, and hyper is upward. So now let's test our understanding for these definitions by these pictures. So this is the first case. Who can tell me what type of strabismus is it?
Is it hypertropia?
Yes, perfect. Thank you. So this is hypertropia because there is upward deviation. Here we can see lateral, so this is exotropia. Here we can see medial, so it's esotropia. And here we can see hypotropia. Now moving to cataracts, how can we define a cataract? Cataract is an opacity of the lens of the eye that causes partial or total visual loss. It can be unilateral or bilateral. It differs in location and severity. Pediatric cataracts are one of the leading causes of blindness. However, it can be curable. So they're common and frequently curable cause of blindness in children. It can present since birth, so congenital, or acquired during childhood. So congenital cataracts, which are less than 1% of cases, can be caused by torch infections, especially rubella, or can be associated with the following conditions: galactosemia, trisomies, Alpert syndrome, or Marfan syndrome. Acquired cataracts, which is more than 99% of the cases, for example, after ocular trauma, radiation, or in diabetic patients. So clinical features, there will be reduced visual acuity, clouding of the lens, either gray, white, yellow, or brownish. Congenital cataracts, they present with different symptoms than the acquired. So we have leukocoria, which is the white pupil, strabismus, deprivation, amblyopia, as we mentioned earlier. So diagnosis is primarily a clinical diagnosis. The first step and most sensitive test in diagnosing pediatric cataracts is the red reflex. So red reflex is an essential part of a newborn exam and should be checked at every visit. So as you can see in this picture, the child has a normal red reflex. The child's you can see red coloration in the child's eye to the pupil. It's symmetrical and bilateral. However, in the lower image, you can see that there is abnormality. The child's left eye is not reflecting red, but is instead appearing yellowish. So lens opacities due to pediatric cataracts, they result in this color. Treatment is mainly by surgery. Now, retinoblastoma, I'm sure you've heard about it before, since it's the most common primary intraocular malignancy in children. Let's try to break down the word. Retinal means retina, which is the light-sensing layer of cells that lines the back of the eye. Blast, which is an immature cell that is not fully differentiated. Oma is just another way for saying tumor. So altogether, retinoblastoma is a tumor that derives from immature progenitor cells of the retina. They are caused by sporadic or inherited mutations in the retinoblastoma gene on chromosome 13. Pathophysiology, it can be heritable or sporadic. Heritable, they tend to be bilateral. Sporadic tend to be unilateral. Now, patients with inherited RB mutations also have a higher risk for developing osteosarcomas. This is very important. Osteosarcoma, which is a bone cancer, and pinealomas, which is a type of brain tumor that forms in or around the pineal gland. For the clinical features, the most notable sign is leukocoria, which is, as we said, white pupil, and it's caused by the tumor refracting light. Strabismus, it can be because of the tumor blocking vision in one eye, so it causes the eye to drift rather than staying in its place. Loss of vision and retinal detachment in later stages. Diagnosis, fundus examination. Then, following fundus examination, if retinoblastoma is found, imaging tests such as ultrasound and contrast-enhanced MRI of the cranium are done to see if cancer has spread to structures around the eye or not. So it's used to identify optic nerve involvement and extent of the tumor. Molecular genetic testing in the RB1 gene is also recommended for all patients with retinoblastoma to determine is it hereditary or sporadic. Now the treatment, it depends on the case of the patient. We have low risk and high risk. If it was low risk, we have different treatment options. Cryotherapy, they kill cancer cells by freezing them. Photocoagulation, by using laser to burn the target tissue. And brachytherapy, which is a type of internal radiation therapy. They use seeds that contain the radiation source and it's placed in the body. High-risk retinoblastomas, they're treated with chemotherapy. Now, congenital glaucoma. This is an important part to be added in this lecture, as glaucoma is the second most common cause of blindness in the world. It's bilateral in 75% of cases, as you can see in this picture. Pathophysiology. So before defining the pathophysiology, let's recall some basics. Trabecular meshwork, aqueous humor, and intraocular pressure. Trabecular meshwork is an area of tissue in the eye that is responsible for draining the aqueous humor. Aqueous humor is a transparent water-like fluid similar to plasma. Intraocular pressure is the fluid pressure of the eye. So coming back, for the pathophysiology, we have primary and secondary. In primary, there is isolated improper development of the trabecular meshwork, so there will be less drainage and increased intraocular pressure. In secondary, we have malformation of the trabecular meshwork, less drainage, and increased intraocular pressure. So this is the trabecular meshwork I talked about. Here it's circled. For the diagnosis, we have increased corneal diameter. In ophthalmoscopy, we can find optic nerve cupping. Optic nerve will be like a cup, and pallor. Genetic testing, example CYP1B1 gene. This is an important gene that's defective in patients with glaucoma. In secondary congenital glaucoma, there will be further diagnostics depending on the underlying disease. Therapy is mainly surgery. Now, retinopathy of prematurity. The best place to start with is with the name. So, retinopathy of prematurity. It's a problem of retinal development that can occur in premature infants. So, we know that the retina, normal retina, begins developing during the second trimester. However, it continues to develop even after a full-term birth at 37 to 40 weeks of gestation. So, definition, it's disease of the retina with abnormal vessel proliferation that affects preterm infants. Who can get ROP? So we mentioned preterm birth infants, birth weight less than 1,500 grams, and oxygen or ventilation administration can also cause it. Now let me explain the pathophysiology using this image. So the developing retina is very sensitive to oxygen levels. Upon sensing high concentration of oxygen, the retina knows that it doesn't need any more blood vessels, and it shuts off vessel growth. However, as the neonate's lungs mature and the supplemental oxygen is removed, the retina begins to experience relative hypoxia. So to maintain this higher oxygen concentration it became used to, the retina will produce the vascular endothelial growth factor, which is VEGF. So this VEGF, as you can see in this image, will stimulate the growth of more retinal blood vessels, which can deliver additional oxygen to correct this deficiency. However, the problem is that these new vessels grow too quickly and are of poor quality, so they end up causing more problems instead of treating the main problem. Treatment is laser photocoagulation, complications, retinal detachment, and blindness, as we mentioned. Now, how can we prevent this condition? You can guess by our explanation so far. So by monitoring oxygen pressures and regular fundoscopic exams. Now conjunctivitis. So first of all, what is a conjunctiva? Conjunctiva is the mucous membrane that lines the inside of the eyelids and the sclera. So conjunctivitis is an inflammation of the conjunctiva. It's called pink or red eye. There are different types. Now, when did the conjunctivitis happen can give you a clue regarding the cause of the conjunctivitis. If it happens on day 1, which is within 24 hours, it's usually chemical. So due to silver nitrate exposure, usually first day, 24 hours, clinical features will be mild infections, non-purulent. Treatment, we can just flush the eye with saline or sometimes use topical erythromycin. Bacterial, we have Staph aureus and H. influenza. Clinical features, there will be purulent discharge because it's bacterial. Treatment is topical broad-spectrum antibiotics. Now, neonatal gonococcal, from its name, etiology is Neisseria gonorrhea. Onset is 2 to 7 days. Clinical features, profuse purulent discharges. This is important. For the treatment, IV or IM third-generation cephalosporin, example ceftriaxone for both mothers and newborns. So we don't only treat the patient, we also give it to the mothers. Then we have chlamydial conjunctivitis. Etiology is C. trachomatis. Onset is a bit later than the others, so it's 5 to 14 days. Clinical features, it's mucopurulent discharge. So neonatal gonococcal was purulent. Chlamydial is mucopurulent discharge. For the treatment, newborns, we give them oral erythromycin or azithromycin. Mother and at-risk contacts, we give them oral azithromycin or amoxicillin for 1 week. In viral conjunctivitis, etiology is herpes simplex virus 2. Onset is within 14 days. Clinical features, we have non-purulent discharge and sometimes periocular vesicles. For the treatment, we use systemic acyclovir plus topical drugs for 14 to 21 days. Now, refractive errors. So during vision, light that is reflected from an object is refracted by the cornea and lens and should be focused on the retina. However, what happens in refractive errors is that the optical image does not accurately focus on the retina. So we have 3 non-refractive errors: myopia, which is short-sightedness, hyperopia, which is farsightedness, and astigmatism. So in myopia, we have abnormally increased axial length of the eye. So what happens is that the distance between the cornea and the retina is too long. So the light ray focuses on in front of the retina instead of on it. So in myopia, close objects will appear clear, however, distant objects will appear blurred. For treatment, glasses with concave lenses are used to reduce the refraction of the light and lengthens the focal length so that the image is formed on the retina. Hyperopia, what happens is that, as you can see in this picture, the distance between the cornea and the retina is too short. So the light rays are focused behind the retina instead of on it, this red spot. So the distant objects will appear clear, however, close objects will appear blurred. Treatment is by using convex lenses to reduce the focal length. Astigmatism, we have abnormal curvature of the cornea. As you can see here, this is the cornea. It's abnormal because the normal cornea is a sphere in shape. However, in astigmatism, it's abnormal. So there will be 2 or more focal points. Normally, we have only 1 focal point, which is on the retina. However, here we have 2 or more focal points. It can be anterior or posterior. It depends on the curvature. Clinical features, it's blurred vision at all distances. It doesn't differ if it's near or far. So it's blurred at all distances. So now this is a study on the incidence of strabismus and amblyopia among children initially diagnosed with pseudostrabismus. The purpose of it was to determine the frequency of strabismus among children initially diagnosed with pseudostrabismus. So they did observations where they assessed age, refractive errors, and presence of amblyopia, and reached the conclusion, which is young children diagnosed with pseudostrabismus are at increased risk of developing pseudostrabismus and also undergoing surgery. I put the link for the study in the notes section if you'd like to read more about it. So, do you have any questions so far? If not, I have some practice questions for you. So who would like to read the first one?
I can read it.
Yes, go ahead, Hannah.
Okay. A 1-year-old boy is brought to the physician for a well-child examination. He has no history of serious illness. His older sister has an eye disease that required removal of one eye at the age of 3 years. Examination shows inward deviation of the right eye. Penlight examination shows a white reflex in the right eye and a red reflex in the left eye. The patient is at increased risk for which of the following conditions? A. Neuroblastoma, B. Blast cell carcinoma, C. Osteosarcoma, D. Wilms tumor, and E. Acute lymphoblastic leukemia. I'd go with C.
Osteosarcoma, yes, perfect. Thank you, Hala. So the clues in this question is that the patient is a 1-year-old boy. He has a sister with older sister that had an eye exam, and in penlight examination it showed white reflex in the right eye and red reflex in the left eye. So this patient is having retinoblastoma, and we mentioned that these patients are at increased risk for osteosarcoma and pineloma. So the correct answer is C, as our colleague mentioned. So this is another question. Who would like to read?
I can read.
Yes, go ahead.
A 3-week-old male infant is brought to the physician for follow-up. He was delivered at 30 weeks gestation by a cesarean section and was cyanotic at birth, requiring resuscitation and a neonatal intensive care unit hospitalization. His mother received no prenatal care. She has diabetes mellitus type 2 and hypertension. She was not tested for sexually transmitted infections during the pregnancy. The infant appears well. Ophthalmologic examination shows tortuous retinal vessels. There are well-demarcated areas of non-vascularized retina in the periphery. This patient's retinal findings are most likely a result of which of the following? A. Retinal malignancy, B. Oxygen toxicity, C. Glucocorticoid deficiency, D. Hyperglycemia, E. Non-accidental trauma. I'd go with B. Oxygen toxicity.
Yes, excellent. Thank you. So this patient is a 3-week-old male. He was delivered via cesarean section and cyanotic at birth. On ophthalmological examination, it shows tortuous retinal vessels, so he's having retinopathy of prematurity. And they're most likely a result of, as you said, oxygen toxicity. So yes, the correct answer is B. So this we reached the end of the lecture. These are the resources that I used. I hope it was clear, and if you have any questions, I'll be more than happy to answer.
It was very clear, Ola. Well done. يعني your topic is extensive review to the common ophthalmic pediatric problems. Yeah, and I think they're all worth to mention as topics and as every pediatrician should be aware of.
Thank you, doctor.
Any questions to Ala?
يعطيك العافية علا. Thank you, everything was clear.
الله يعافيكي. Thank you, Anoud.
Thank you, Ala. Well done.